This presentation covers pacemakers, okay? And we see in this picture a permanent pacemaker. And it has two components, including the pulse generator, which has a sealed lithium battery and an electronic circuitry package. The pulse generator produces the electrical signals that make the heart beat. Many pulse generators also have the capability to receive and respond to signals that are sent by the heart itself. This permanent pacemaker also has a second component, which are wires, and these wires are called leads. Leads are insulated, flexible wires that conduct electrical signals to the heart from the pulse generator. The leads may also relay signals from the heart to the pulse generator. And so in this diagram, we see the various components of an implanted permanent pacemaker. As we're continuing to talk about the leads, one end of the lead is attached to the pulse generator, and the electrode end of the lead is positioned in this picture we have one in the atrium, the upper chamber of the heart, or it can be placed in the right ventricle, the lower chamber of the heart. In the case of a biventricular pacemaker, leads are placed in both ventricles. Pacemakers can sense when the heart's natural rate falls below the rate that has been programmed into the pacemaker's circuitry. Okay, so that's a term that we need to become familiar with, that pacemakers can sense when the heart's natural rate falls below the rate that's been programmed into the pacemaker's circuitry. Pacemakers can have 1 to 3 leads depending on the patient's heart condition. Pacemakers are programmed to suit the patient's specific requirements using a pacemaker programmer. Patients with pacemakers should avoid powerful electromagnetic fields, which may reprogram the pacemaker. MRIs, magnetic resonance imaging scans, cannot be performed on patients with pacemakers for that reason. Pacemakers are used to pace the heart when the normal conduction pathway is damaged or diseased. The pacing circuit consists of the power source, always called the pulse generator, and the leads, could be one or more, and then finally the third element is the myocardium itself, the heart muscle. The electrical stimulus has to travel from the pacemaker through the leads to the wall of the myocardium. Now, at the end of the leads is a small hook or anchor, which is not shown on the previous slides in the diagram, but in reality there is a little hook there, and that hook needs to get buried within the myocardial tissue. Once that is placed, the pacemaker is placed, it takes time for that little anchor it takes like a week for it to make sure that it is sealed in there. Okay, it has to be there for that circuit to be complete. It has to be like buried into the myocardium. There is a risk that it does not get buried in there and the lead does not make contact with the myocardium, and so then of course the pacemaker would not work properly. So the next term that you need to become familiar with is capture. We talked about sensing Now we need to talk about capture. The myocardium captures that stimulus and causes the myocardium to contract. Okay. There is a risk that in the immediate period of the first week or so before that my anchor has been buried into the myocardium, there is a risk that the patient could move and dislodge it. And we certainly don't want the lead just in the bloodstream. That's not going to help anything. So we instruct our patients not to raise their arms above their head until until they return to their doctor visit to make sure everything is properly healed from having the pacemaker implanted. So they should not go out and play basketball. No jumping and shooting hoops, because that raising your arm up could dislodge the lead from the myocardial wall. Okay. Let's look at how a permanent pacemaker is implanted in our patients. Typically, they'll go to the cath lab, the cardiac cath lab. It's not a long procedure, but they frequently leave the floor and go down to cath lab to have this pacemaker inserted. It's a small device, and it's implanted under the skin, and it'll send electrical signals to start or regulate a slow heartbeat. An implanted pacemaker may be used to stimulate the heartbeat if the heart's natural pacemaker, which is the SA node, is not functioning properly. Or if they've developed an abnormally slow heart rate or rhythm, or if the electrical pathways are blocked. Okay, so we're talking here bundle branch blocks, AV blocks, those type of things, bradycardias, an SA node, sinoatrial node diseased. Some things like those conditions will lead a patient to be a candidate for a permanent pacemaker. So we see here in the picture that there's a subcutaneous pocket is made on the chest, and it is simply slipped into that pocket. So they'll have a small incision when they return to the floor right here. And then we have the leads that are advanced through the subclavian vein down through the upper vena cava or superior vena cava, and then the leads are hopefully the little hooks will make contact with the myocardium and heal, so that they are not easily removed or dislodged from that placement. Okay. This slide shows a single chamber pacemaker. In other words, they have a single lead. Now the lead can be in the atria, or it could be in the ventricle. This particular diagram shows a ventricular lead. Okay, but I'm going to talk to you about both of them at this point so you understand that you could have both an atrial or a ventricular chamber that is paced. So if a patient had an atrial arrhythmia, and that's an arrhythmia caused by dysfunction of the sinus node, or the patient has developed another atrial pacemaker within the heart tissue that takes over the function of the sinus node, that can certainly happen. It can be treated with an atrial permanent pacemaker whose lead wire is located in the atrium. But like we see in this picture, a ventricular arrhythmia, an arrhythmia caused by a dysfunction of the sinus node, an interruption in the conduction pathways, or the development of another pacemaker within the heart tissue that takes over the function of the sinus node, may be treated with a ventricular pacemaker whose lead wire is located in the ventricle. Okay. It is possible to have both atrial and ventricular arrhythmias, and there are pacemakers which have lead wires positioned in both the atrium and the ventricle. As we see here, it's called a dual chamber pacemaker. There may be one lead wire for each chamber, or one lead wire may be capable of sensing and pacing both chambers. I think on the last picture, but it shows after they have a pacemaker placed on a previous diagram, it did show that the incision site is covered with an occlusive dressing. Okay, it is very important that we don't want it to become infected, and it's not rare, I will have to say it's not rare, in which it does become, the implanted pacemaker does become infected, and you will encounter patients like that who have to go back to the cath lab and have it removed because it did get infected. And then they would, of course, get rid of the infection before they put a new pacemaker in that patient. Okay, they'd have to clear up the infection first. But remember, an occlusive dressing will keep it dry and keep debris from falling into that incisional site. Okay. Here we see a patient who has had a permanent pacemaker inserted or implanted in his subcutaneous pocket on his left chest area. Now, fortunately, having a pacemaker implanted is only a minor surgical procedure. This is not open heart surgery. However, in this picture, you do get other clues about this patient's medical history because he does have a mid-sternal scar indicating that he had, in the past, open heart surgery. After a pacemaker is implanted, most people resume their previous lifestyle with little or no limitations. Just want to mention again, except for that first week or so, we don't want them raising their arm above their head because it could dislodge the lead from the myocardium. But the procedure alone is, the patient may have some mild sedation and a local anesthetic. They're not put to sleep. There's just like a 2-inch incision just below the collarbone. And pacer wires are then inserted into the vein and advance through that vein using fluoroscopic guidance into the heart. Let's see, the generator itself is only about 1/2 inch deep and 1.5 inches wide. Okay, so it's relatively small. But the skin is then sutured closed and the patient leaves the hospital later that same day or returns to the floor. Incisional pain is mild and transient, but it is possible to feel the pacer generator under the skin, and you can visually see a slight deformity of the skin. For most people, that's not an issue, but for some women, it could be an issue in terms of not allowing them to wear the type of clothes that they might want to wear and making it visible. So that is something to think about as well. Okay. Okay, so here is a chest x-ray, and even on chest x-ray, some other information that it reveals is if a patient has a pacemaker. The small object in the upper corner is an implanted pacemaker. Patients are instructed for a week after the procedure to keep it dry, the incision dry, and avoid excessively exerting the arm on the side of the pacer. After a week, the patient will resume their prior lifestyle without limitation. Household appliances do not interfere with modern-day pacemakers. However, mobile phones may. They should be kept 12 inches away from the pacemaker when they're on, when your cell phones are on, and preferably at the ear on the opposite side of the pacemaker. A mobile phone should never be left in a pocket overlying the pacemaker. Okay. You can even see the leads if you follow it from the pulse generator. You can follow the leads down into the heart as well. Of course, you lose visibility because of the whiteness there, but you can definitely pick up on this on X-ray. So we've talked about permanent pacemakers, but now we're going to talk about temporary pacemakers. The difference is that with a temporary pacemaker, the power source is outside the patient's body. And there's 3 different types. We'll talk about one of them in particular. So there are 3 types we'll talk about: transvenous, epicardial, and transcutaneous, because we will see these being used on cardiac floors in hospitals. Okay, so sometimes we have reps come in and have workshops to educate and update the nurses and the staff on the use of temporary pacemakers. And this is what it looks like. This pacemaker would be sitting generally on the bedside table for these patients. In temporary pacing, the wires are threaded. In this case, you see through the basilic vein, but could also be through the internal jugular vein. They are threaded onto the epicardial surface of the heart. Okay, and they can exit through those access points that we saw either on the chest or in the arm. So we can definitely use temporary pacemakers, especially as a bridge for the patient who is going to be scheduled for a permanent pacemaker placement. All right, so remember, we also use these for our 3rd-degree heart block patients, or even a 2nd-degree heart block, perhaps a Mobitz type 2, when there is the patient is not getting good cardiac output. Okay, so we will talk more about this, but with a pacemaker spike should be followed immediately by a QRS complex. In other words, we should see that when there is a stimulus made by the pacemaker, we should have a ventricular contraction that follows it. Pacing spikes seen without a subsequent QRS complex implies the loss of capture. If there is no capture, then there is no ventricular depolarization and contraction. The nurse would have to assess for cardiac output. Keeps coming back to cardiac output. And how does the nurse assess for cardiac output? Well, of course, we use our vital signs. And certainly we cannot ignore the level of consciousness of our patient. Okay, so that is how we can determine if there is a loss of capture. So now let's look at our EKG rhythm strips and determine if a patient has a pacemaker. When a pacemaker initiates an impulse, it appears as almost a straight line on the EKG tracing strip, and we call those spikes. Okay, so clearly you see in these strips here where the red arrow is pointing that there is a straight line that looks different than any type of normal electrical activity of the heart, of the natural heart. So this stimulus appears as a little straight line or spike. It's very obvious to anyone who has experience with EKG interpretation. And you can easily recognize this as well. Now, one thing you will note is that the ventricular contraction does not look like a natural QRS complex. Okay? Remember how we like a narrow QRS complex, a very efficiently contracting heart? That is not what we find. Instead, we find this very wide and bizarre looking, and it always looks like this. Okay? So in this top picture, that is very characteristic of a pacemaker EKG strip. Now notice, is there a pacer spike before every QRS? Now the QRS is a downward deflection in this picture, and this is how it looks. And is there a ventricular contraction following every pacer spike? And you will have to say yes. And we would refer to that patient as being 100% paced. P-A-C-E-D. Okay. And if you look below, you also see a pacer spike, and that looks a little different than the other one. And there's a reason why it looks different. Of course, the spike looks very large for one thing, but where does the pacemaker spike fall? Before the QRS? No, in fact, the QRS looks normal, like what we would expect to find. This pacer spike comes before the P wave. Yes, that little thing, that little wave after that spike is the P wave. So what does that tell you about this particular lead? It goes into the atrium. So when the atria is stimulated by this impulse, the atria contract, and then the ventricle contracts, okay, all by itself. So we have in this picture both a ventricular lead and an atrial lead. How do we know? Because of what follows the spike. On the top, we see the spike is followed by a QRS. On the bottom, we see that the spike is followed by a P wave. The pacemaker spikes are artificially induced by the electronic stimulus of the pacemaker. That's why they look different. In this case, you see the line and then the QRS that follows it, the spike. And what's pointing upward is basically like the T wave coming back to the isoelectric line. So this is simply a ventricular pacemaker, and it is 100% paced. So it causes, that pacemaker, when a patient has one, it causes a spike on the EKG waveform. And here we're showing you the difference. We see the spike is very obvious. We see 4 spikes in this little strip. What follows the spike, this is the one that's a little more difficult to recognize, because what's following the spike is not a QRS. If you look at not maybe the first one, but the second, third, and fourth ones, it's clear that after the spike, there's a P wave. And again, sometimes the P wave is inverted. So it can look different, but this is exactly what we can expect to see when a patient has a pacemaker. Okay, so this is an atrial pacemaker. And this is a picture of a ventricular pacemaker. Again, look at the spike, and immediately following the spike, we have a ventricular contraction. Okay, and again, it appears to be 100% paced in this individual. Remember that if the heart is doing its own initiation of impulses and has a contraction, there is no need, and the pacemakers are programmed, it's a little computer, it's programmed not to throw a spike or impulse. If the natural heart is doing what it's supposed to do, the pacemaker will not throw, and should not, I should say, throw a pacer spike or impulse. Okay. And so then we have this case where we have an AV pacer. So it's both an atrial and ventricular pacemaker. It's a dual chamber pacemaker. Sometimes they call it AV sequential pacemaker because first in the sequence, the atria contract and then the ventricles contract. Okay. We see two spikes. The first spike there is followed by a P wave. And that P wave indicates that there has been capture in the atrium. Now, I know that the P wave doesn't look really pretty, and sometimes you might even question whether it's there, but there is an abnormal P wave as a result of having that atrial lead. And then we have that second spike, and that produces a ventricular contraction. So therefore, we know that the ventricular myocardium captured that stimulus because it resulted in a contraction. Again, that QRS complex is wide. It does not look like a normally generated QRS. Okay. And you can see that in both the upper and the lower one. Both of those are pictures of dual chamber pacemaker spikes. Okay. Problems can occur with pacemakers. We're going to talk about the first problem or malfunction of a pacemaker, and that's called failure to sense. Remember what sensing was. Failure to sense is failure to recognize spontaneous activity of the heart, and so the pacemaker fires inappropriately. The atria or ventricle, whichever the leads, wherever they are placed, should not, if they are working properly by themselves in the natural heart, the pacemaker is not supposed to fire an impulse. But what if the pacemaker does not detect or sense the fact that the heart is doing what it's supposed to and fires anyway? That would be inappropriate firing, and that's because the pacemaker cannot sense the electrical activity of the heart itself, the natural activity. So what can cause a pacemaker to malfunction because of failure to sense? Well, things like battery failure. We could have a battery failure, or the lead is damaged. Okay, maybe the lead is not even in contact with the myocardial wall. So there could be dislodgement of the electrode or damage to the lead, mechanical issues. And so here we have a picture. We can detect failure to sense by looking at the EKG strips. And so if we follow along with me, as we see, starting on the top, tracing, we see a pacer spike, and we see a QRS. And as we go along, oh look, there's a P wave, a QRS, and now we have another pacer spike. So you see that this is not 100% paced because we have a natural beat of the heart by the heart itself. So if the P wave comes along and we have a normal atrial and ventricular contraction, there's no need for a pacer spike. Okay. But it is programmed so that if it's not, the P wave does not contract, and the computer senses that, it is going to throw a pacer spike, and that's exactly what happens in the next step here. We see a pacer spike thrown, and we see a ventricular contraction. Then we see a P wave and a ventricular contraction. But then, what is this? What's going on here? There was no reason for that pacer spike that's close to the arrow. That didn't even let or sense whether or not the normal beat was going to occur. So it threw an inappropriate spike. The pacemaker does not recognize the normal beats and generates an unnecessary pacemaker spike. Now there's another malfunction that can occur with pacemakers, and that's referred to as failure to capture. Failure to capture is electrical charge to the myocardium is insufficient to produce atrial or ventricular contraction. Okay, so we do get an impulse from the pacemaker to the myocardium, but it does not capture it. It's not adequate to result in a contraction. Again, the things that can lead to failure to capture include battery failure, damage to the lead, and dislodgement of the electrode. One other thing here is fibrosis at the electrode tip. Remember, at the electrode tip, there's like a little hook or anchor, and that gets lodged into the myocardium, and over that first week, some scar tissue begins to form, and it keeps it in place, which is great. That's what we want to happen. But on occasion, there can be too much scar tissue that develops, and that prevents the electrical charge from the pacemaker making contact with the myocardium sufficiently enough to produce a contraction. Okay, let's see what that looks like on an EKG tracing. Here we go. Now look at the pacer spike. The very first one on the left shows a ventricular contraction and a T wave, and we see another spike and a contraction, and then we see that third spike. Does it result in a myocardial contraction? No. So this is failure to capture because it definitely discharged an electrical impulse, but it was not captured adequately sufficiently enough to result in a ventricular contraction. Okay, so that is your example for failure to capture. A third type of failure can be simply a failure to output. And this is when the pacemaker does not generate a impulse or pacemaker spike when it is needed. So clearly in the top, we'll look at the top one first, there's this long pause. That's when the heart is not beating. There's nothing going on there. This long pause. Clearly the pacemaker should fire, and it does not. And so that can be failure to output, and certainly that pacemaker is no longer functioning. Or you see in the bottom the same case. In fact, the pacemaker spikes in this one look very small. Okay, so there is failure for the pacemaker to generate a spike that's sufficient enough to result in a contraction. Look at that. That's you can imagine what's going on in terms of the patient's cardiac output during this time. Okay, I think we would institute an immediate temporary pacemaker if this were the case, because we need to get that pacemaker replaced. It's not working. So I want you to understand this major point here. Patients get pacemakers because they have electrical conduction problems in the heart. A lot of times they have electrical conduction problems because they have heart failure. On top of that, remember we talked about heart failure patients having that overstretched left ventricle and how that can actually disrupt and alter the electrical conduction pathways in the heart itself. So when you have a failure to output or a malfunctioning pacemaker, the heart is not pumping. Okay, and if the heart is not pumping and moving blood forward, what is going to happen? Think about what we've been studying. There's going to be a backup of blood and pressure. It's going to back up and cause high pressures in the lungs and force the liquid portion of the blood into the lung tissues. And then the patient cannot breathe. They present exactly like a heart failure patient. So you should be able to make that connection. Okay, again, we're always pushing toward making these connections, not just learning about failure to output and then not continuing on with that thought process. So if the heart is not pumping during this time, the patient could become symptomatic as a result of the decrease in cardiac output. So make those connections. We do not ever assess equipment and monitors. No, we always assess the patient. So we have to get skilled with our assessments as well and knowing what can lead to what, right? Complications as a result of this malfunctioning. Oh, okay. We have gotten so advanced in terms of what these little computers can do. Okay, so we're going to move on and talk about even more advanced technology in terms of the implantable cardioverter defibrillator, or sometimes we call this the AICD or ICD, A for automated. Okay, so an implantable cardioverter defibrillator, or ICD, is a small device similar to a pacemaker. It's implanted under the skin in a subcutaneous pocket, often in the shoulder area just under the collarbone. An ICD senses the rate of the heartbeat. When the heart rate exceeds a rate programmed into the device, the ICD delivers a small electrical shock to the heart to slow the heart rate down. Many newer ICDs can also function as a pacemaker by delivering an electrical signal to regulate a heart rate that is too slow or pace out of a rapid rhythm. An ICD has a lead wire that is positioned in the ventricle as it's used for treating fast ventricular arrhythmias. Okay, the ICD is appropriate for patients who have survived sudden cardiac death. Remember that torsades often leads to sudden cardiac death. And we didn't study much about it, but sudden cardiac death is a little bit of a misnomer because not everybody dies with sudden cardiac death. Okay, I do have a resource for you to access on your worksheets. So if you look into your worksheets, you will see that there are sources there for you to learn about sudden cardiac death. But as the name implies, but not as the name implies, not everybody dies who has sudden cardiac death. People do survive it, but they are at a much higher risk of undergoing another event, cardiovascular event. And so an ICD would be very appropriate for people who have survived this. We see it a lot for patients who have ventricular tachycardias. Okay, remember how it goes. We have ventricular tachycardia is followed by ventricular fibrillation and then asystole. Okay, so can you imagine how life-saving this ICD can be? So patients who develop and have recurrent spontaneous VTAC, which will lead to their death, should have an ICD. So if any person that's at high risk for any life-threatening dysrhythmias would be a good candidate for an ICD. We also have, we didn't discuss this, but electrical physiology studies are done in the hospital. Our patients go in there, and the purpose of going for an EP study is to induce an arrhythmia. They want to induce the arrhythmia so that they can examine the circuitry within that patient. Before they go down for these studies, they are taken off of their anti-arrhythmic medications, okay, because they go there intentionally to induce that patient's arrhythmia. Now, if they induce an arrhythmia in this patient and the patient faints, then they are a candidate for an ICD. Okay, they can save their lives with this little implantable device. What it consists of: a lead system. Again, it's advanced through the subclavian vein to the endocardium, just like our pacemakers we just discussed. It is battery powered. Pulse generator is the other component, and it's implanted subcutaneously. So there's not a lot of differences there. But the ICD can sense the heart rate of the patient and the rhythm. Okay, I'd say it's sort of like having your own personal teletech right in there. And it can identify VTACs and VFib. And then approximately, because these are all programmed individually for patients, approximately 25 seconds after detecting this arrhythmia, life-threatening arrhythmia, it's going to deliver energy and shock the person. It doesn't need a lot of energy, usually 25 joules or less. Now, the deal is this, that if the shock is unsuccessful, it's going to continue to shock the patient. It's going to deliver successive shocks until it corrects that arrhythmia. Okay, so we say that the ICD recycles. Now, this is a discussion that the patient will have with their cardiologist, because it's not a pleasant experience when they're shocked, and likely they're going to scream because it's unexpected. They may not know it's coming, or even if they know it's coming, when the shock is delivered, they may scream out loud, and they may have a headache, and they may not feel good afterwards. Okay, sometimes the patient will know, who has an ICD, that they're about to be shocked because they can feel their heart racing. They can feel any subsequent symptoms because of their heart going so fast and the decreased cardiac output. So they have to decide how many times are they willing to be shocked or want to be shocked before they wanted to stop shocking them. Okay. Now, ICDs are equipped with pacemakers. They're equipped with anti-tachycardia and anti-bradycardia pacemakers. This is just, to me, amazing what these ICDs are capable of doing. If the patient has a very fast rhythm at tachycardia, there is a supraventricular tachycardia, which we call SVT, or a ventricular tachycardia, as we've studied, it can initiate pacing, and it overdrive pacing to slow down that rate. It can also provide a backup pacing for very slow rhythms, bradydysrhythmias that can occur. Especially, imagine, this is not uncommon, that a person with an ICD is shocked because they have a very fast VTAC or VFib. They are shocked, but what rhythm comes out of it is not a normal sinus rhythm, but instead they come in with a bradycardia. Okay, then the pacemaker kicks in and provides pacing to speed up the heart rate. Frequently, the pacemaker is set at a 72 beats per minute. That's the most common one. It's very important that the nurse provides education regarding the ICD. Again, there are a variety of emotions that are possible when a patient has an ICD implanted. One of them is the fear of body image change. Not for all. These days they're very small, so it doesn't cause that much of a disturbance, but it can be an issue for some patients. This one is the fear of recurrent dysrhythmias can become very real. They never know as they're going about their daily life whether they're going to be shocked. Their heart's going to go into a dysrhythmia and they're going to end up being shocked. They could be driving their car. Then they would have to know, hopefully they're in touch with their body, they can feel their heart racing, they can pull the car off to the side of the road and then they're shocked. Or they could be walking in the middle of the Publix and all of a sudden they're shocked. So there's a lot of anxiety with that, and there is pain when the ICD discharges. Certainly not a pain-free event. So part of that for our patients with ICDs may be to encourage them to participate in support groups so that they can address all of those type of emotions that go along with having an ICD. Okay, I've included a couple of questions here. NCLEX style questions is what I call them. This is multiple choice. After teaching a patient who has an implantable ICD, a nurse assesses the patient's understanding. Which statement by the patient indicates a correct understanding of the teaching? Okay, hopefully you selected B. We did mention that in this presentation. I will avoid sources of strong electromagnetic fields. The patient being discharged with an ICD is instructed to avoid strong sources of electromagnetic fields. Patients should avoid tight clothing, which could cause irritation over the ICD generator. The patient should be encouraged to exercise, but not engage in strenuous activities that cause the heart rate to meet or exceed the ICD cutoff point, because the ICD can discharge inappropriately. The patient should continue all prescribed medications. Okay, so this, just because you have a pacemaker or ICD does not mean that you discontinue your anti-dysrhythmic medications. No, that would hopefully prevent a lot of dysrhythmia. Continue taking the medication, and then hopefully the ICD will not have to discharge as often. Here's one more question. A nurse cares for a patient with an IV intravenous temporary pacemaker for bradycardia. The nurse observes the presence of pacing spikes, but no QRS complex on the patient's EKG. What action would the nurse take next? Hopefully you selected B as in boy. The pacemaker spike should be followed immediately by a QRS complex. Pacing spikes seen without subsequent QRS complexes imply loss of capture. If there's no capture, then there's no ventricular depolarization. The nurse would assess for cardiac output via vital signs and level of consciousness. The other interventions would not determine if the patient is tolerating the loss of capture. Okay, I believe that's the end of this, and I'll sign off.